not right now. All right. So last time we left off watching The Office perform CPR in a very educational video in which they perform CPR to the beat of Staying Alive, which is accurate. Maybe I shouldn't eat this chocolate. It's really drying me out. Okay. For those of you that are not already familiar with CPR, I know we keep just diving right in. I really did used to fit all these lectures into a single hour. No wonder people were like really overwhelmed by the amount of content. CPR, adult CPR, in case you're not already familiar with it, is basically pro trainings.
Now in all CPR or patient care, the most important thing to check before you ever engage in care is whether or not the scene is safe.
Okay, well, we're not going to actually listen to this guy. We can just, if you want to watch him give his whole demonstration of CPR, I encourage you to later, using his very live dummy. That's actually a person. So you start with 30 chest compressions with your fingers interlaced like this. You locate the location approximately between the nipples and interlace your fingers and push, and you should feel actually the sternum, the breastbone, actually like physically go down, like you put that much force on it, which is why you usually are positioned like that. After approximately 30 chest compressions, and they are hard, you know, like you do want the sternum to go down. You don't want to like injure the person, but you do have to push pretty hard. You're trying to actually like physically jumpstart their chest. You administer 2 rescue breaths, and that's where you pinch the person's nose, tilt their head back, pull their mouth open, cover their mouth with your mouth, and then blow in twice. And you should actually like watch their chest because it should rise whenever you blow in. Then close it all up, interlace your fingers, bump, 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 do another 30 times. Now, this is a cycle. You don't have to do mouth-to-mouth if you're not comfortable doing mouth-to-mouth, and if you're lucky, you have one of those devices, some kind of a barrier that will prevent you from like directly putting your mouth around someone else's, because there are a couple of reasons why that might not be ideal. The number one being STDs and other saliva transmitted diseases. Am I too dark right now? Can you see me? I feel like you can see me half the time and not the other half. There we go. So you should just repeat the cycle until paramedics arrive. That's the first thing you do, is always call 911, obviously. Although, rip that cops will be involved. That's the worst part. If you're not comfortable doing rescue breaths, which is what those are called, mouth-to-mouth is also known as rescue breaths, then you can just continuously do chest compressions. I really, really recommend that everyone takes a CPR training at some point in time. You really don't know when you might need to use it. It's not that complicated. Now here is one that you really don't have an excuse not to know how to do because it is so simple. The boxes of Narcan actually come with instructions for how to use them, right? And it is extremely easy. Narcan is almost always administered as a nasal spray by laypersons. If you're a healthcare practitioner, you might have an intramuscular injection, or I think that's like the primary use one. I don't even think it's intravenous is primary. If someone knows more about that, then feel free to interject. But when you administer Narcan to someone, you do so via these nasal spray things. And it's 4 milligrams of Narcan in each of them. And the idea is to take the plunger, put it in a person's nostril, press the plunger, put it in the other nostril, press the plunger. That administers the full dose of Narcan. If they are not conscious or not breathing, or particularly if they're not breathing, if their heart rate is super slow, if their heart is stopped, in particular, administer CPR. You know, like that's when you should administer CPR, is when their heart is stopped, like they don't have a pulse. If their heart rate is really low, you need to be monitoring them in case it stops, but you don't need to administer CPR on someone who is like breathing. So again, using Narcan is very easy. You can see right here, you literally just like place, inside of nose, push, or press. Okay, I guess it says press. And then administers half the dose, put it in the other nose. And you can see that this person in this diagram is in the recovery position. So administering Narcan is like extremely easy. If they're not responding every 2 or 3 minutes, you can give additional doses. In some cases, if someone has been like severely overdosed on something, it might take 4 or 5 doses of Narcan to revive them. Now, the way that this works is that in the brain, opioids fit into opioid receptors, right? And that is what allows them to exact their mechanism of action, which is reducing central nervous system activity, inducing sedation. So that is what Narcan reverses. There's a reason it's called overdose reversal, because you are physically going in with like a crowbar and knocking the opioids out of the receptors. That's what Narcan does. It boots them out of the receptors. Now, because of this, in some cases, it has been reported that people might come out of an opioid overdose after being Narcaned, feeling very agitated or disoriented, in some cases aggressive. Someone that took DrugsCo in the past had a sister who was in a syringe exchange program who Narcaned people on a regular basis who would come out swinging. Now, this is not necessarily a regular occurrence, but it is something that you should be aware of, because when opioids, which is the sedation and bliss chemical, are knocked out of the receptors in the brain, then the person whose brain is being toyed with in that level is probably not going to be particularly comfortable or oriented. So be aware of that. Also, if someone is Narcaned and they come out of it, they still need medical attention. In some cases, the opioid overdose reversal is it's not enough to forego any additional like health consequences that can happen, especially if someone had stopped breathing for a period of time, in which case you probably had to administer CPR for them to start breathing again. But don't just like Narcan them and be like, they're good. You should still get medical attention for them, because there are many vital signs that need to be monitored after that fact. So I want to clarify this, because this is, I think, a big point of confusion, is what exactly kills you from different drugs. So if I asked you, for instance, like, how does heroin kill someone? A lot of people would be like, well, it just like, it shuts you down and you die. But do they actually know how you die? So I want to debunk that real quick. In the case of depressants and opioids, generally speaking, a person would die from lack of oxygen because their breathing is slowed, their heart rate is slowed, their blood pressure drops, which means that their body and their brain are not getting enough oxygen. Because of this, this can lead to decreased functionality in the heart and in the brain, which can lead to cardiac arrest in some people, because it's a heart attack. Like you have a heart attack from irregular heartbeats and too little oxygen. Like a lot of things can lead to a heart attack, but like having too little oxygen is one of the things that might lead there. So lack of oxygen is the thing that kills you from depressant and opioid overdoses most of the time. Withdrawal from depressants kill you from seizures, first and foremost, because of suppressed brain activity that just is like pushed down as a spring and is suddenly released. Withdrawal from opioids can kill you, but it's not very common. A lot of the time, this would simply be accompanied by just very serious discomfort. But death does not usually come from opioid withdrawals. Overdose, sure, but withdrawals are quite a bit less high risk to do than withdrawing solo from, for instance, benzos or alcohol. Overdose from stimulants can result in cardiac arrest and arrhythmia, which is an irregular heartbeat, and overheating. And overheating, in turn, can cause a lot of other problems that stem from that, like cardiac arrest as well from overheating, and seizures. So your concern with overdose on depressants and opioids is too little oxygen. Your concern with withdrawal from depressants is seizures. Your concern with withdrawal from opioids is being highly uncomfortable, and in some cases it can cause death from other complications, usually though. Or overdose on stimulants usually would cause some kind of like cardiac arrest or some heart problem. That's probably one of the biggest issues. And overheating, internal body temperature, can cause brain damage if your body temperature gets too high and other shit. Now, coming back to this chart, which we've seen a million times before in a whole bunch of different forms, and we'll see in the next lecture that we're going to start and maybe even finish today, this is the relative harms chart that was established by the Independent Scientific Committee on Drugs, and we're going to learn about that today. I know we've seen this before. Alcohol has been deemed the number one. Now, what might be some conflating factors in this chart? Why might alcohol be number one? What is a criticism that people might have of alcohol being the number one on this chart as opposed to the other drugs? Can anyone think of
commonly used?
It's commonly used. Exactly. So it kind of begs the question of whether or not we're going to see different things when drugs are implemented as easily accessible substances. Not many people would open up about taking other drugs. Yes, that's true. So the critique that some people have, or not even the critique, but the question that some people have when I show them this chart is, isn't alcohol the most accessible? Ergo, when we make other drugs, if we make other drugs that accessible as well, won't we see their relative harms go up? But the way that this is established, this overall ranking of harms is established, is a lot more contextual than that and takes a lot of things into consideration. Also, alcohol is more normalized, so people may be less careful or thoughtful about using it. Yes, these are all true things. So keep that in mind. We're going to come back to that. Just to get some things out of the way that you might have heard before, but might not be 100% certain on, detox or detoxification is to address physical dependence, physical withdrawals from substances. This is an intervention technique that is usually implemented when a person is having difficulty getting off of a substance themselves for physical concerns and complications. Usually often involves other medications that are kind of augmenting this process of detoxification. And then after detox, treatment is started. And this is a more psychological thing. So first you take care of the body and make sure that if there is any kind of physical dependence on this substance, that is weaned off of appropriately in whatever form. And then you move on to the psychological realm of the treatment. So this could be for a person that has a psychological dependence on a substance, that has an addiction to a substance, or merely that has a problematic relationship with a substance. And those three things can happen in any mixed and matched formats. So one such example of this is getting off of alcohol, because alcoholism, as some of you might be more familiar with than others, is really, really serious shit. Alcoholism is highly genetic as well. And there are two main ways that it's treated. I'm sorry for these blocks of text. One of them is Naltrexone, which is when you take it before taking or drinking alcohol. When you take it before drinking alcohol, it basically blocks the positive reinforcement effects of it. So instead of you drinking alcohol and you feeling rewarded for doing so, you might drink alcohol and just like not really feel anything, emotionally speaking. And the way that this happens is that it's an opioid antagonist. So alcohol, being an opioid antagonist, as well as traditional opioids, would feel less rewarding than it would otherwise. Alcohol makes you feel rewarded, news to me. Well, something that is a substance that induces cravings of some kind will be reinforcing and rewarding, right? So it gives you more reason to do it, and it makes you feel good while you're doing it. So if it feels good to drink, and if you get something out of it, then that contributes to that craving. So in the case of alcohol, it might feel good to drink physically because it either just simply feels good and is a GABA agonist, or because it makes you feel less shitty, but either of those things, that is reinforcing, and rewarding because it satisfies some need that you have. So in this case, this is kind of trying to reduce those elements, but this is really controversial and not highly applied because after just one study, it was put onto the market, and there was a ton of lobbying that went alongside it. So a lot of political influence to getting this drug approved. So you get the reduced coordination and judgment without the uninhibited feeling. No, it's more like the kind of like more blissy aspects of alcohol are less prevalent. It just doesn't feel as satisfying to drink. But that doesn't necessarily mean that this is an effective way of helping people stop drinking. Then the other option is Acamprosate or Camprol, which reduces your physical withdrawal symptoms. And the idea here is that it increases your GABA functionality, so you don't have as many of the serious side effects that you would from tapering off of alcohol, but this needs to be used in conjunction with therapy. So the idea behind Camprol or Acamprosate, whatever, is that this reduces the physical aspects of feeling garbo while trying to not drink, but it doesn't solve the mental issue that can come with drinking for some people. Yeah, these are prescription. And then there's Antabuse. And this is definitely, I would say, the more controversial one as far as I'm aware. This is basically like disincentivizing drinking, because normally your body has enzymes in the liver that kill the hangover-inducing chemicals produced by alcohol. So those liver enzymes are partly responsible for making you not as hungover as you could be if you didn't have those enzymes. But Antabuse prevents those enzymes from doing their thing. So it is intentionally giving you a shit hangover right away when you drink. Now, there are a couple of problems with this, probably mainly that people are probably not going to really want to keep up with this treatment regimen, because if they know that they're going to be drinking regularly, giving themselves self-induced hangovers every time is a really hard treatment plan to follow. The other thing is that even though drinking still sucks, even though drinking sucks now, you still crave it. Like, it doesn't take care of any of the underlying issues that make you crave it in the first place. It just makes you disincentivized in the moment from doing it. In the process of withdrawing from alcohol, benzos are frequently used as an aid to this, because when you are removing that pressure from that spring on GABA, your brain has the potential to go into seizure mode and have a lot of really terrible consequences. Like in this case, this is showing delirium tremens. Remember, it's the severe agitation, it's the severe side effects that come with hallucinations of withdrawing from alcohol. Now, if you add benzos into this can reduce the likelihood of other complications like seizures, for instance, because your spring is being pushed down by something different. So your body can detox from alcohol, but at the same time, you're not really at risk of having this like crazy rebound that can cause excitotoxicity and heart failure, etc. So this is part of why detoxing with the presence of a medical professional can be really, really important, and also reduces your mortality rate from alcohol withdrawal by so much, is because something as simple as adding a benzo into the mix can really do a lot. Unfortunately, this sometimes means that people that previously had alcoholism then just switch over to having a problematic relationship with benzos because they're such similar substances. So it's a really double-edged sword. I bet that a lot of you have heard of Suboxone and Methadone, and Suboxone is known as subs, and Methadone is sometimes known as juice, depending on where you're at, but not that commonly. Both of these are opioid substitution treatments, otherwise known as OST. And these are becoming increasingly available across the country and all over the world, unfortunately not in Russia, which really needs them. But the idea behind this is that if you're withdrawing from opioids, you can't really function, right? Like, your ability to live your life is severely limited. But if you introduce a new drug into the mix that kind of satisfies that neurological itch for having the opioid receptor filled, but doesn't really get you high like opioids, like recreational opioids do, you don't go through the withdrawals like you normally would, but you don't feel high and impaired. So the whole idea behind this is help people kind of put a stopper in the withdrawal process and allow them to figure out what they need to do to move forward, without the pressure of being like, I'm going to be dope sick, I'm going to be dope sick, I'm going to be dope sick, I'm going to be high. This is really effective for a lot of people, although a lot of people also report that coming off of both of these is worse than coming off of the drug that they were on in the first place. So it is a temporary thing. In many cases, the idea is to taper off of these as well. Some people end up having terrible, terrible problems with them. Most people report that they've saved their lives. Now, something interesting that you might notice on Suboxone, otherwise known as subs, is take a look at the two drugs here. Buprenorphine is the actual opioid that's like kind of partially binding to the receptor, but not getting you as high. And then there's also Naloxone. And does anyone remember what Naloxone is? Come on. I'm sure that one of you knows what naloxone is. No? Wow, okay. Naloxone is Narcan. That's just the chemical name for Narcan is naloxone. Why do you think that this treatment would involve buprenorphine and Narcan? Why would that be the case?
You not get addicted to the buprenorphine?
Your mic was really quiet. Can you say that again?
Helps you not get addicted to the opioid, to the buprenorphine, because it doesn't bind so tightly?
Partly the naloxone does interfere with binding. The other thing here, though, is that the way that this is administered, the way that Suboxone is administered, means that if someone tries to get high on it by, for instance, snorting it, whatever the form is, it doesn't always come in these sublingual strips, right? It can come in pills as well. If you try and get high from it, you're going to get Narcaned right away. So that's actually an abuse prevention tactic that happens, because sometimes people will try and crush and smoke these pills or to crush and snort them. So the Narcan is just like, fuck you, you try and do this, it's just not going to work for you. And then there's Ibogaine, which we kind of briefly touched on in the past. In Mexico, these clinics are becoming increasingly popular, and frankly, it is one of the most successful addiction treatments that we have, especially for opioids, actually. Unfortunately, a lot of people are at risk of very serious heart complications from doing Ibogaine, which makes this kind of a last resort deal for a lot of people who feel desperate enough to quit whatever their substance is, that they would travel to Mexico and have an Ibogaine treatment administered to them, knowing that there are risks affiliated with it. This being said, most of the risks affiliated with it are improper administration of it, right? The person that's giving someone else Ibogaine really needs to know what they're doing to avoid cardiac complications like arrhythmia and liver problems. And if they don't know what they're doing, which is a problem that we see all the time in these kinds of markets, then it can be potentially very serious for people. Then there's Kratom, which is one of the most popular means of tapering off of opioids in particular. It's very popular. We're going to come back to it, I think, this next lecture that we're doing. Kratom is an opioid derivative, so it has kind of a similar mechanism of action, but it's not quite the same. And it's much easier to obtain legally in the United States. However, some people really underestimate Kratom and believe that it's a completely non-addictive substance and that they can just kind of swap it out. And some people have had really serious complications from inadvertently becoming dependent on Kratom as well, or in place of something else. But this is a major, and often very, very positive way for people to reduce the agony of withdrawal from opioids is Kratom. Now, here's my word of caution. People that do drugs don't go into a drug experience being like, I am going to develop a problem with this substance. If they do, there's probably something else going on with them, so that's beside the point. But that's not a typical mentality that people approach their drug use with. People aren't often like, oh yes, like this is going to be an issue for me. Instead, it's frequently with the mentality of, I can beat this. Like, I know other people have had problems with this, but like, I'm different. I can do this. It's not an issue. I just want to put out a word of caution that there is no drug that is superior to another drug. You know, all drugs are just drugs. They have risks. They have potential rewards. They're all just different, unique substances, and they should all be legal, in my eyes, regardless of what they are. What matters is the context of use, right? And some people are far more predisposed to problematic relationships with drugs than others. Like, that is a definitive fact. In fact, I think this slide is outdated because my current stance on this is that the context of your use is much more important than the actual drug that you're using. However, it is definitely important to approach drug use without the mentality of, I can beat this. I know some people have issues. I'm not like those people. Be humble when you look into the face of drugs, because after a certain point in time or after a certain kind of experience, it's not about your willpower anymore. It's a neurological thing. So I'm just saying pay attention to your context, pay attention to yourself, trust your intuition, but also be prepared to be humbled if you need to, and be prepared to prepare yourself, really. Okay, let's talk about clinical trials. What is the most dangerous part of serious alcohol or benzo withdrawals? Most dangerous part of withdrawing from depression.
Seizures.
Excellent. Which substances can cause fatal withdrawals?
Either alcohol or benzos.
Mm-hmm.
Once in a while, opioids, but rarely.
Yes, excellent. What aspect of substance use disorders does detox seek to address? What is the purpose of detox? Yep. Physical dependence. All right, short recap. This guy, David Nutt, okay, I've been kind of hinting at this man for a really long time now. David Nutt was employed by the British government. Look at that guy's face, he's cheesing. He wrote a paper on ecstasy saying that doing ecstasy was safer than riding a horse. And the government did not particularly like that. There's the horse on ecstasy, and there's David Nutt as a nut. So the government basically said, or he was fired from the government because he released a lecture where he basically was like, weed is not as dangerous as the government says it is. And the government was like, look, we can't really employ you if you're going to be a government official that is directly releasing statements in contradiction with what the government is trying to say. And like from a governmental perspective, sure, I can see why they would say that. It's kind of like, wow, he's really going against what you guys are trying to get across. But at the same time, it's like, you got to take new information in consideration. So here is, for the millionth time this semester, whatever, David Nutt's respective harms chart. So he, in I think 2009, 2010, founded the Independent Scientific Committee on Drugs, which basically was this committee in the UK that was like, we're going to figure out what actually is going on. And they released this scale, which really made waves within the drug researching and scientific community and really made people think a lot more critically about how they categorize drugs and what exactly the potential harms were of various substances and why. Now, I do have some qualms with this, namely that crack cocaine and cocaine are listed so distinctly because crack cocaine and cocaine are the same drug, except one is smokable. That, I think that they should be categorized the same, and it's the routes of administration that should be made different. And he also raised a bunch of money to fund LSD research. So, for many of you, psychedelics are your main point of interest in this course, and now I'm going to hit you with some science. I have a kind of stupid question about this chart. Is the harm to users supposed to be the sum of both bars, like for alcohol 72, or just the dark blue bar? No, they're separate. Harm to users is the dark blue bar, harm to others is the light blue bar. They're distinct things. So MRI results of acid. This was a quasi-recent thing that we've been able to do as science has taken more of an interest in psychedelics as time has gone on. This particular study was looking at the visual cortex of the brain. So the area of the brain that examines visual input, right? Otherwise known as the occipital cortex. So here we have cerebral blood flow. CBF is cerebral blood flow. It's hard for me to say. And this is under placebo. Now, the lighter the areas, the more blood flow is taking place. And then this is under the influence of LSD. Now, this might not look like any distinct change to you, which is why they so kindly separated them out and showed the respective difference from people that are sober to people that are on acid. And what they showed is a stark increase in the amount of blood flow to areas of the brain that deal with visual information. So when you are under the influence of LSD, your brain is firing in such a way that it is creating visual information when there isn't actually any input. This is part of the basis for visuals, that you get open and closed eye visuals. And one of the theories behind this is that especially for closed eye visuals, your brain is given a blank slate and it basically fills in the space with what it deems should be there. Yeah, it's interesting, right? That's known as complex visual imagery. Now looking at kind of a different area, and this is one of the most interesting things that I've ever learned about acid, and something that I love to talk about, is looking at the parahippocampus. Now, the parahippocampus is memory storage. This is the area of the brain that puts things that have happened. And usually, when you are trying to make sense of your environment, the visual cortex of your brain communicates with your parahippocampus to look at what's going on around you and to pull visual information and kind of attach it to your memories, to attach it to things that you already know. This is how you might walk into a room and see a water bottle with a sticker on it on the table, and like somewhere in there have a memory of being in a place with your water bottle, or knowing like what that water bottle, like something like that. It attaches past experiences to present visual input. It gives meaning to what you're seeing. Now, under the influence of LSD, normally there's actually less communication between those areas, which is why you might walk into a room you've been in a million times before and it feels unfamiliar, because the context that your memory storage is usually applying to what you're seeing isn't connecting. But as soon as you add music into the mix, suddenly it's reversed and that connection is increased. That's why music is one of the most substantial influencers of how a trip can go. Because when you play music, you are actually increasing the personal attribution of your memories to a space. And this can give a space entirely new, contrived meanings. Like you pick up a chocolate bar and it reminds you very vaguely of something that is connected by like 15 Kevin Bacon nodes away. Like it's a really far thing from the actual chocolate bar you're looking at, but it still incites a feeling and incites a memory. This is also what is likely responsible for closed eye visuals. So on the right, we have increased communication between your visual cortex and the resting state circuit, which basically means that there's more visual activity happening than there normally would be. And then below, there's increased blood flow to your memory regions from music. So all these little red bits, orange bits, whatever, are increases in blood flow to memory regions. There have been other studies on this that have shown that music that was previously meaningless to a person gains meaning on LSD, especially music that contains a lot of human voices and timbre and very kind of natural sounding instruments. And this is just like another example of how different areas of the brain have substantially increased blood flow to them while you're under the influence of LSD. So on the left is before, on the right is after. This is like sober versus LSD side by side. So you can see how the activity increases, but also changes in where it's taking place in all of these regions. Now, because of this increase, we're seeing through researching LSD how people might give meaning to music in the first place, and how people might give meaning to things in general in the first place. The areas of the brain that work together to take in information and be like, oh, this means something to me. This makes me feel something. So LSD is actually giving us this better understanding of why we feel meaning towards certain things and not others. Now, another part of the parahippocampus, again, this is the memory storage area, is that it communicates less with the resting brain, which basically means, like I said before, that you will come into a space that was previously familiar and it might feel unfamiliar. It might feel like you haven't been there before. People feel less familiar, etc. And this also means that you have less of a sense of self. Your edges are blurred, so to speak. Your experiences and your perceptions are tied less to past experiences. And this is thought to be one of the reasons that we might see that people are able to make such significant behavioral changes and changes in thought patterns following the use of psychedelics, is that previous experiences aren't informing their responses to things as much as they did. And this can be really helpful, especially in therapeutic settings, when someone undergoes a process of changing the way that they intentionally respond to something, because your brain chemistry will probably stick it a little bit more effectively than before. So over here we see the blue representing decreases in blood flow to areas that are usually responsible for thinking about yourself, for thinking about autobiographical thinking. Now, this is known as the default mode network. The default mode network is a network of neurons in your brain that does its thing when you're resting, when you're basically thinking about nothing, when you're staring into space. It's responsible for autobiographical thinking, and in the same vein, might also be responsible in part for anxiety and depression. People that have depression have been shown to often have higher levels of activity in their default mode network. In other words, ruminations. Thinking excessively about the self, comparing the self excessively, too much brain activity in the regions that make you think about yourself, especially in ways that can induce anxiety. Now, this is part of the reason, again, that we might be seeing such decreases in depression and anxiety in people that are in psychedelic-assisted treatment. And this also is a possible explanation for ego death and softening. So, just to recap, because I know that was a lot of charts and information. Visual activity in the brain goes up. No shock there. There's less communication between your stored memories and your visuals unless music is present, in which case there's more communication. Oh. Things that previously did not have meaning gain meaning on acid, and us researching this is helping us understand why and how we attribute meaning to things ever in the first place. There is less blood flow to regions of the brain that are often responsible for depression and rumination, and there's less communication between your memories and your sensory input, which gives a novelty to the space that you're in and the people that you're with that might be lost otherwise. This is kind of part of the reason that a lot of people have an easier time playing on acid, being silly on psychedelics than they would normally, because novelty is restored. One of these studies that has been conducted on this was about LSD and near-death depression, because obviously a lot of people that have terminal illnesses feel a lot of really pressing and constant depression because they know that they're going to die and they're faced with their mortality. So in this particular study, patients were given LSD, and then following the administration of LSD and concurrent administration of therapy, their overall amount of anxiety drastically decreased after the treatment ended. Drastically decreased. Psilocybin has been shown to be, I think, actually even more effective than LSD for near-death depression. Approximately 80% of patients that were given psilocybin mushrooms with terminal conditions reported retaining antidepressant effects 6 months after the treatment. 6 months later. That's a really long time not doing any drugs after having been given them. Generally, psilocybin is considered to be a more spiritual experience therapeutically than LSD is, and also can contain kind of a more complicated subset of emotions and experiences as well. And frequently, this makes people feel very emotionally connected to others. In this particular study, we're looking at, again, this concept of blood flow. And in this case, we see a massive decrease in blood flow to the amygdala, which is the area of the brain responsible for processing fear. So these are like people that were depressed, right? And after being treated with psilocybin mushrooms, or psilocybin extracts probably, there was less blood flow in the area of their brain that processes fearful emotion. That's interesting, right? It's interesting. And over time, people's general depression levels drastically decreased as well. This, I think, is a little bit too complicated. So if you're curious about the more gnarly neuroscience aspect of things, you can come back and check out this later. But basically, psilocybin is known for participating in what a lot of people would consider to be a reset to a healthier pre-trauma state. So helping kind of reduce and regulate brain activity in areas that had been heightened too much or shut down by trauma. So psilocybin is really wild. There's a lot of complicated brain regions in here, and I would be lying to you if I said that I remembered this entire lecture from scratch, because I've been too busy to look over any of them for a while. So I'm not going to try and explain this without looking at my notes first. But what I will say is that these treatments have produced incredibly profound antidepressant effects that have been very long lasting. In this particular case, this region of the brain is part of what encodes emotional value, subjectively speaking, and it's activated after psilocybin. So in 2018, the FDA approved a landmark study on psilocybin and depression. This means that it was fast-tracked, basically, as showing such incredible promise. And after the study is completed, it could be on the market for therapeutic treatment in as little as 2 or 3 years. Yes, the FDA, the Food and Drug Administration, is looking at magic mushrooms as being a clinically effective treatment for depression. As of right now, the Imperial College of London is carrying out microdosing studies. The Beckley Foundation is carrying out microdosing studies. The Heifer Institute is currently on stage 3 clinical trials for psilocybin in treatment of treatment-resistant depression in cancer patients. And we've seen this before, so I'm not going to go into it.
Peaceful, joyous, incredible, life-changing experience I've ever had in my life. There were scary parts, foreboding parts. I always knew there was beautiful and joy and peace on the other side of it. It was freeing. It was really freeing.
This is Alana. She's describing what she felt after she took a dose of this stuff, psilocybin. It's a naturally occurring psychedelic compound, the kind that you find in magic mushrooms, but she wasn't tripping in a room with stock. It actually wasn't recreational at all.
If anything became unreal or I was feeling nervous or not in touch with reality, I would squeeze his hand and he would squeeze mine back just to reassure me that I was okay and everything was all right.
It was part of a controlled medical test to see if psychedelics could be useful in helping people quit cigarettes. Alana had been smoking for 37 years before her session with psilocybin, and she hasn't had a cigarette since. Research on psychedelics for medical use is preliminary. Most studies suffer from really small sample sizes, and that's partly because the federal government lists LSD and psilocybin as Schedule I drugs, so researchers face extra red tape, and funding is really hard to come by. Vox writer Herman Lopez reviewed dozens of studies that have been done, and he found that psychedelics show promise for treating addiction, OCD, anxiety, and in some cases, depression. One small study of 15 smokers found that 80% were able to abstain from smoking for 6 months after a psilocybin treatment. In a pilot study of 12 advanced cancer patients suffering from end-of-life anxiety, participants who took psilocybin generally showed lower scores on a test of depression. And a smaller study suggested that psilocybin treatment could actually help people with alcohol dependence cut back on their drinking days. We don't have all the answers as to what exactly these treatments are doing in the brain, but they seem to work by providing a meaningful and even mystical experience that leads to lasting changes in a patient's life.
The issues that I talked about or thought about or went into during my experience were transformative in the sense that I got to look at them through a different lens. I know it sounds weird. I feel like I have more connections in my brain that I couldn't access before.
That feeling that Alana is describing is actually pretty spot on. When you take LSD, your brain looks something like this. You can actually see a higher degree of connectivity between various parts of the brain. It's not limited to the visual cortex. This communication inside the brain helps explain visual hallucinations, and the researchers argue that it could also explain why psychedelics can help people overcome serious mental issues. They wrote that you can think of psychiatric disorders as the brain being entrenched in pathology. Harmful patterns become automated and hard to change, and that's what can make things like anxiety and addiction and depression very hard to treat.
The reason that those kinds of conditions are so difficult to treat is that there's something more to them than just the illness.
That's Albert Garcia Romu. He's a Johns Hopkins researcher who's worked on studies of psilocybin and smoking addiction, like the one that Alana's involved with. He says that when participants take psychedelics,
they have very profound, meaningful experiences that can sometimes help them to make new insights into their own behaviors and also to kind of reconnect with their values and priorities in terms of what's very important to them.
One of the big remaining questions here is how long these benefits actually last after the one-time treatment. A review of research on LSD-assisted psychotherapy and alcoholism found no statistically significant benefits after 12 months. And a recent study on psilocybin and depression found that benefits significantly dropped off after just 3 months. And of course, there are some big risks to using psychedelic drugs. It's hard to predict a patient's reaction, and some might actually endanger themselves. Those predisposed to psychotic conditions are especially at risk for having a traumatic experience while on the drug. It's difficult to draw solid conclusions from the existing studies, but there's more than enough promise here to merit further research and further funding for that research. As Matthew Johnson of Johns Hopkins said, these are among the most debilitating and costly disorders known to humankind.
And UC Berkeley just received a $1.2 million seed grant to open a new psychedelic research and education center as soon as possible. So that video is now outdated. Then there's MDMA-Assisted Psychotherapy, which I know that I have talked about before. It is in stage 3 clinical trials and maps the Multidisciplinary Association for Psychedelic Studies. Just completed I think a $30 million fundraiser for the final push for their MAPS campaign, or for their MDMA campaign. This is, again, designated as breakthrough therapy. And breakthrough therapy basically means that it was fast-tracked for how incredibly promising it was. I think that I've shown you guys this information before, but the patients that participated in studies about MDMA-assisted psychotherapy saw an average of 68% no longer qualifying as having PTSD after an average of almost 18 years of having severe PTSD. Only approximately 20 to 30% of people in PTSD treatment actually respond to their treatment. And this is just going to continue having more and more data pushed onto it. I need to see this right now. I don't think we do, but if you're curious about it, feel free to hop in here. Then there's ketamine. There is not currently direct involvement from the government in ketamine treatment for depression. However, as I've said before, we've seen that ketamine symptoms or symptoms of depression can be lessened within a day of treatment, often within hours, which makes this a very effective treatment for suicidal patients. Now, it's short-acting, it's short-lasting, 10 to 14 days for antidepressant effects from ketamine. It's not that long, and there are significant bladder concerns with using K2 frequently, right? Like, that's a big issue with a lot of these treatments, is that bladder concerns like ketamine cystitis are real things. However, they're around twice as effective as SSRIs and work immediately. So we're continuing to examine ketamine as treatment for depression at this moment in time. There goes that video. All these, I'm just speeding through this because I want to do the thing. Now I want to talk about some new drugs, some things that we have not spoken about before. Yes, it's so exciting. So synthetic cannabis, I know that people have asked me some questions about this in the past. I know that we also just sped through a lot of information. So some common names for synthetics are spice and K2, and frequently these are sold in head shops and smoke shops and gas stations. There isn't a specific term for using them, but oftentimes they'll be purchased by people that either don't know the difference or can't get their hands on legal weed. They usually start out in liquid form that is then sprayed onto plant matter or potpourri. Kind of looks a little bit like this. Some of it looks very convincingly the same as weed. And frequently people just can't really tell the difference between them, especially if they don't have that much exposure. Although it really is like, you know, it's potpourri. It doesn't come in nugs typically the same way that weed does. Unfortunately, synthetics are notorious for their health risks, especially agitation and heart palpitations, other cardiac confusions, seizures, and issues with coordination. A lot of the time, synthetic cannabinoids contain other things like rat poison, for instance, and can be highly, highly addictive substances. So always exercise caution with synthetics. There's actually been like a spate of emergency department visits from people that have smoked synthetics without realizing it and had really, really severe adverse reactions. So if you know someone that was like, my friend smoked a joint laced with fentanyl, and you're like, how do you know it was fentanyl? And they'll be like, oh, I started freaking out. Your friend probably smoked spice or even a PCP dip joint, but probably not. It was probably just like spice. They just probably smoked spice. I remember a while ago, people would tell me that rat poison would be cut with some MDMA pills like 9 years ago. In very rare cases, I'm sure that happened. It's more likely for rat poison to be cut into like a really cheap, heavily adulterated drugs like Paco, for instance, which is a form of crack found in South America somewhere, I think. But things like that, and shisha, which is like Greek meth, like street meth, can be cut with stuff like rat poison. That's the most common area for that. Since this stuff is often sold as potpourri or incense, because that's how people get away with selling this kind of shit, it's labeled as not for human consumption. It doesn't stop anybody. Because of the issues that have been faced by it, there has been some kind of criminalization put in place about synthetic cannabinoids, but new ones are being made all the time, particularly the JWH subtypes, so JWH18, JWH73, and this was initially made by a researcher to help research the cannabinoid system, but people got their hands on it and started producing it and distributing it on their own. So most emergency department visits that are marijuana related come from synthetics and not actual cannabis. Then there's modafinil, on a completely different subject, and modafinil is a really interesting one. It is otherwise known as Modalert or Provigil. It is available by prescription in the United States, and it's specifically prescribed to people that have narcolepsy as a waking agent, or truck drivers or pilots or members of the military. It's intended to keep you awake, and it's not as recreational as other drugs like Adderall. So for this reason, modafinil is what's classified as a nootropic. And a nootropic is a drug that's supposedly a cognitive enhancer. It's a performance-enhancing drug, basically. So modafinil does a lot of shit. It's a dopamine reuptake inhibitor, norepinephrine reuptake inhibitor, serotonin agonist, glutamate agonist, histamine release agent, and that's a lot of stuff, you know? So from that, we can draw that it's a stimulant because it increases the effects of dopamine and norepinephrine, right? A cognitive enhancer for some people because stimulants frequently act as such, and glutamate is a connective agent, and a waking aid. Those are what we can take away from this kind of chemical profile. So it's touted frequently as being a memory aid, as being a cognition aid, as being a performance enhancer. And honestly, modafinil does not have very many side effects except headaches and nausea. However, it's possible that if you take it too frequently, you could get really serious skin side effects that could hospitalize you. So it's not very common at all. My friend asked his dealer for M and consumed it at work thinking it was modafinil, but it was actually MDMA. Oh, no way. That's terrible. Oh, that's like so terrible. Did he have fun at least? Best day of work of all time. So modafinil is a really, really complex substance because it has implications for being used in even things like people who have schizophrenia to reduce their active symptoms, to reduce their inactive symptoms like brain fog and disconnection, but also in like breast cancer patients, chemotherapy patients, post-chemotherapy to enhance cognition and improve attentiveness. Now, we don't really have that great of an understanding of how modafinil works, but what we do know is that there is an increase in connection between sensory areas of the brain and decision-making areas of the brain. So there's not a lot of data on how effectively modafinil actually increases your cognition. In fact, as far as I'm aware from last I read, it is not shown to actively increase your cognition and your memory, but it's very effective for staying awake for long periods of time and staying on your A game, especially socially, or if you just have to get stuff done. So modafinil is a really cool one. It's a really interesting, strange thing. Now, it used to be prescribed in the United States, and in some cases, I think you can still get it prescribed, but it was really rolled back. It's not a heavily abused substance. It's very unlikely to cause any kind of physical dependence. It is not reinforcing and rewarding because it's not a fun high. There aren't really many side effects, and we don't even see tolerance building. Like, you can take it several days in a row and not have a marked decrease in effects. So why was it pulled from the shelves? And one of the answers is that between 1998 and 2007, there were 6 reports of severe skin reactions. That's 0.8% of users that have some mild reaction to modafinil, as opposed to these 6 severe ones. And that's known as Stephen-Johnson syndrome. It's a pretty terrible disease that starts out as a rash and then spreads across your body and can kill your tissue. And you don't want to get Stevens-Johnson syndrome. But Stevens-Johnson syndrome is more common with something like ibuprofen than with modafinil. So that begs the question of why exactly did these 6 reports over the course of 9 years cause it to be pulled from the shelves? One of the potential answers is that this was approximately around the time period that Adderall started becoming really popular. So the question is whether or not there might have been some kind of external push for these severe skin reactions to be paid closer attention to by the FDA. I don't know. I'm not a conspiracy theorist. I actually am not sure. But yeah, people frequently use modafinil because it's a Schedule 4 drug, so you can get it imported with a prescription, but it's not sold really within the country. Or actually, I want to fact check that because I know people that have prescriptions for it, but I'm not sure what the history of them are. Then there's LSA, and this is morning glory seeds. You can actually buy these at Home Depot, but there's a reason that more people aren't tripping on morning glory seeds. We'll come back to. Also, Hawaiian baby wood rose seeds contain LSA. Very heavy body load, a much lighter visual load, some cognitive high, but not as much as LSD. There's a lot of severe nausea reported from morning glory seeds and after effects like being kind of brain foggy and headachy afterwards. But LSA has a similar neurological mechanism that other psychedelics do. It's a psychedelic, very sedating and less visual, and about as 10th as potent as LSD. So you need to kind of like figure out how many seeds you have to eat to get the LSA effect. Then there's 4-FA, 4-fluoroamphetamine, which is a research chemical that is an amphetamine, like a euphoric stimulant, basically, that doesn't deplete your serotonin like MDMA does. So this is really popular in Europe in particular because people would be able to take it every weekend without feeling that same kind of like I am out of serotonin sensation that MDMA might bring onto them. It really was kind of like popular in the US for a brief stint in 2014. It is a dopamine agonist, serotonin agonist, norepinephrine agonist, and it's a releasing agent, a reuptake inhibitor. So that combination of things makes it an empathogenic stimulant that is mostly stimulating but has some light kind of rolly empathogenic qualities. Yeah. Now here's the thing about 4-FA. Know that these charts are really scary. This was a study that was done on 4-FA to kind of monitor its physical effects. This lighter bar shows the heavier dose of 4-FA. This darker bar shows the lighter dose of 4-FA. This is different kind. This is systolic and diastolic blood pressure. These are blood pressures basically over time. And what we see is that the heavier dose of 4-FA causes huge spikes in blood pressure, and heart rate as well. And the high, like it all coincides with itself, right? Except for the heart rate, which is like just generally a bit higher. But this massive spike in heart rate or in blood pressure was so significant that they actually cut this study halfway through because the higher dose was just like proving to be physically dangerous for people. Now, one of the major things that was kind of revealed after 4-FA became popularized and started moving over to the United States was that it comes with a really high risk of cardiovascular problems because of this huge spike in blood pressure. Now, I think that most of the time when I say there's a risk of cardiovascular problems, unless you already have high blood pressure, you probably are like, Rachel, I don't give a fuck. I'm probably not going to be impacted by this. And honestly, in most cases, like if you're not using stimulants really frequently, and if you're not taking a really high dose of them, it's probably not going to be that big of an issue to take a stimulant because your cardiovascular system is not going to just like immediately explode. With something like 4-FA though, what we've seen is that there have actually been research reports released saying if you experience a severe headache on 4-FA, stop taking it immediately and go to the ER. A severe headache in the case of 4-FA has been led to cerebral hemorrhagic strokes, which basically means that your blood pressure is so high that blood vessels burst and start bleeding into the surrounding area. Now that's a little bit of a stroke, you know, like it's a mini stroke, sometimes a major one. We're not exactly positive how 4FA works, what its mechanism of action is, but it is very, very, very hard on the heart, and the blood pressure rise is extremely intense. So some people can take 4FA a million times and have no issues. Some people, even with low blood pressure, can take 4FA for the first time and kind of spontaneously have this massive spike in blood pressure that causes a hemorrhagic stroke. So if you or someone that you know uses 4FA, make sure that they're aware of the fact that lower dosing is really important for safety reasons with 4FA, and also that if you, it's not easy to get anymore. It was for a couple of years, I think 2014 to 2015, it was like really popular in the US again. But you really need to be hyper aware of the fact that this is not a fake risk. This is a very real risk of 4FA, to the point that it's like listed in documentation. And again, it really can happen just kind of spontaneously. It can depend on what kind of food you've eaten, etc. Yeah. Yeah. As with all drugs, it has a risk and reward ratio. The most important thing to be aware of with 4FA is this very real risk of your blood pressure spiking, even if you have low blood pressure. And it's not fake. Like, I can tell you with extraordinary confidence that even people taking it for the first time can have hemorrhagic strokes out of fucking nowhere. And yes, I have personally witnessed this on several occasions. So, moving on to kava. Oh, actually, we're out of time. That's the end for today. I will see you guys on Tuesday, and we might actually finish the class on Tuesday. So, have a great weekend. See you later.